because there's just so much going on in spine surgery. So I think these are my disclosures, which won't affect what I'm talking about today, but there really are no set rules. And I think we've seen the rules being stretched a little bit in the last few years. And so when we say who should be doing spine surgery, the easiest answer is, well, surgeons, right? Whether you're ortho trained, neuro trained. I don't think there's a lot of ortho guys, at least coming out now, that aren't doing spine fellowships that are doing elective spine surgeries, or at least complex spine surgeries. And I just don't really see that. So I would say if an ortho person, and they probably need to be fellowship trained. I think with the neurosurgery, you get a lot more exposure to the spine. I can tell you the residents at USC where I'm at, they get a ton of spine, and by the end of their fourth, fifth year, and they're going into their chief year, they're very experienced. And I think the programs probably vary, but I think certainly they could do a spine fellowship, but I don't think it's absolutely necessary. I think the next category really is sort of the pain management interventionalists and the radiologists, right? They're not surgeons, but when you look at it, I mean, the pain management interventionalists, they do a lot of procedures. They do things that are small surgical procedures. They're doing spinal cord stimulators, they're making incisions, they're closing, they're dealing probably with the complications of that, and so they are doing surgical procedures. And the radiologists are doing interventional procedures, and they kind of cross over into the surgical realm. And so that is just a fact of life, and in some ways, and later in my talk, I kind of welcome that. And I think sometimes, I remember when kyphoplasty first came out, a lot of the surgeons were like, oh my gosh, we got to take care of this. We don't want to lose this and things like that. I feel exactly the opposite now, and I'll show you why later. And then the next category are probably people who are non-surgeons, like physical therapists, chiropractors, primary care people, PAs, and nurse practitioners. And I think that seems like a no-brainer. But obviously, when you get in the leadership of certain societies, you see a lot of people asking for sort of an advocacy or some type of, I wouldn't say formal support, but you get a lot of people asking, like, would you support this doing this? Would you support a therapist doing this and things like that? And you'd be really surprised at some of the requests that come in, for example, through NASS. Now, one of the things about these professional societies, I can't speak for all of them, but I can tell you NASS has never restricted practice. There's been a lot of things going on, and I guess I would defer to JJ. You were president, I think, 2005. I would think growing up to 2005, he was encouraging NASS to be multidisciplinary. I can tell you, when I was on the board through my presidency, we used to get a lot of requests about restricting practice. We get requests from surgeons like, the radiologists are doing this, these people are doing this, these people are doing this, do we have to do something? And NASS has never gone through that. NASS has never taken a stance on that. I don't know if other societies have done that. It really probably hasn't come up. I think obviously there are professional medical societies within each specialties. I don't know if there's certain guidelines there. We certainly have medical boards, and that kind of borders on, I think, what really drives things, at least would be sort of the medical legal aspects of things. And one of the problems, I think, with the setting guidelines that are really sort of rigid is that there's such an overlap of specialties, right? There's neuro, there's ortho. You know, we have some of our ortho spine fellows going into practice, and I was a little surprised that one of our guys did an integral tumor, but he had worked with Patrick and John, and he felt very comfortable doing that. And I wouldn't suggest that all our ortho spine fellows go out and do that, but he felt very comfortable doing that, and he did it. And so there's a real overlap between ortho and neuro, especially in spine. Crossing the dura, there's a little bit. Obviously, there's the pain management folks, putting in interspinous spacers, doing kyphoplasties, potentially injections, doing some of their small interventions. And then there's the vascular surgeons and the radiologists. I mean, I can tell you, the first time I used Sal Brow to do my vascular approach, I was up in my office, I got a call and says, Dr. Wang, Dr. Brow says, if you don't come down here soon, he's going to take the disc out for you. And I wasn't used to that kind of speed. The guy had the thing exposed like in 10 minutes. It was just crazy. But obviously there's a lot of overlap here, and it's kind of hard to set guidelines. So I thought I'd bring up some points for discussion on who'd be doing spine surgery, because I can't make that call. I don't think any of us can really make that call. But these are kind of the four areas that I thought we would consider. Number one, obviously, is spine surgeons. Now, in spine surgery, all of us who are surgeons, we've been trained. We have basic training. We understand the biomechanics of spine. We understand the anatomy. We had to learn the basics of that. There's a certain board certification with our individual specialties in neurosurgery and orthopedics. In orthopedics, we don't have a spine a board certification, but I mean, we've studied this. We spend our lives, and every day we do surgery, right? That's what we do every day. And I kind of look at it like pickleball, right? I mean, anyone can go out there and just hit the ball. But there are some people, and some people I know, that are really intense about it, and they study it, they take lessons, they watch videos, and they do all this kind of stuff. We're kind of like those people as surgeons. Doing a surgical procedure, we've delved into it, we kind of understand it. And there are other people that maybe are non-surgeons that can come and hit the ball a little bit and do some spine surgeries, but I think we have a deeper understanding of it. And so I would imagine that patients would want a trained specialist. They don't want someone who's learned a procedure in a weekend course. They want someone who's learned at least the basics in the training. They understand the biomechanics, the anatomy, the basic science behind it, stuff that we all had to learn in residency and take those in-training exams. And we were trained in surgery. And so I would think that the patients would want that, but I think it obviously gets a little difficult in today's world with all the marketing and things like that. Now, to be on the counterpoint, there are new procedures that we take weekend courses for, right? That we didn't learn in our training, and we do learn things. Endoscopy is one of them. I've taken several weekend courses in cadaver labs, and we're finally starting to do it. But that's not something I learned in my training. And I know that I feel like I'm equipped to handle the basics. I know the anatomy. I feel like I can address it in more traditional ways. So if I have a problem, I can open it up and do something to kind of fix it. But at the same time, there are a lot of people who can take those weekend courses. And I think when I was talking to Tony Young, I don't think he's doing surgery anymore. I know that he was having trouble getting people to adopt endoscopy, and he and his companies were going towards the pain management folks to try to do endoscopy. And there's probably pain management folks out there doing endoscopy right now. So that's one area to look at. And I think the second area are the complications. And this is where I think it gets a little more concrete, because you're going to have complications, right? I mean, name one procedure, or even if it's an injection, that you don't have a complication. And if you're doing the surgery and you're the surgeon, you should be able to deal with those complications. And you shouldn't have to rely on others to correct those mistakes. And I think that's one of the biggest arguments we used. That's what I heard when radiologists started doing vertebroplasty, kyphoplasty. If they get cement leakage, who's going to go and open up the canal and clear it, right? Who's going to take care of those complications? And you could sit there and say, well, the radiologist can't deal with that. The pain management folks can't deal with that. What if they're doing the mild procedure and you get a dural tear and you have to go in and repair it and things like that? So that's one stance to look at. To be fair, doing these types of procedures, the counterpoint is that as surgeons, we can't deal with all the complications, right? I remember when I was at UCLA and we bought Santa Monica Hospital, and we were going down there and we were putting in, doing fusions and stuff like that. They didn't have vascular surgery in there, right? So, I mean, how many times you get a vascular injury, but theoretically, if you got a vascular injury, we would have had to call in a vascular surgeon, whereas up at the main campus at UCLA, we had vascular rooms. We had people in clinics. We could just call someone in and they'd be able to deal with it. So you can make the counter argument that we can't deal with those vascular injuries. Although I think we could probably deal with it better maybe than a non-surgeon. We could probably flip the patient and make the incision and find it. I can tell you that I did an ACDF, and one of my patients clotted the vertebral artery. And I remember talking to my good friend Dan Rue, and he said, yeah, some of these patients are predisposed to that. You just retract the longus and they clot the artery. And the guy had a mini stroke. And I was thinking, like, wow, that's kind of, I'm not going to deal with the stroke. But thankfully, there are a lot of medical people that deal with it. My spine fellow at the time was a neurosurgeon, and he just called me up and said, Dr. Wang, this guy was exhibiting some weird things, so I just got a brain MRI. And yeah, he had a mini stroke. And I was like, what? And he was like, yeah, he was like really calm. He was showing me the MRI. He goes, yeah, here's the brain MRI, and showing it to me. And I was like freaking out. And he was just like, yeah, we just give him some aspirin or something like that. But I looked at it as, wow, and that made me also think about outpatient surgery. Lateral lumbar interbody fusion. What if you get a bow injury? I mean, we could probably find the bow. We could probably sew it together. We would do a good job. It's not what we do. So you can argue that we can't handle that complication. We, as surgeons, do some injections. I don't do injections in my practice, but there are some surgeons that do injections. Now, obviously, if you have a complication, you could probably deal with it, but there again is that overlap. Spinal cord stimulators. We heard great talks on spinal cord stimulators. I know some spine surgeons in private practice that are putting in spinal cord stimulators. And then I already mentioned vascular approaches by spine surgeons. You talk to the vascular guys that are doing all these approaches, they feel like they could probably do the discectomy, because it's pretty simple, right, to do a basic ALIF. We make it sound more complicated, but it's kind of simple. The third area, I'm almost out of time, current practices. So we talked about Germany. In Germany, there's a lot of trauma surgeons that do spine because it's part of the same thing. So a lot of the trauma surgeons, Rudolf Beissy doing thoracoscopic surgery, he's a general surgeon, trauma surgeon, he was doing spine surgery. Southeast Asia, when you do spine courses there, a lot of them do trauma also. They don't just do spine surgery. My father-in-law was a general surgeon in Uniontown, Pennsylvania. He fixed fractures, he had to. There's no like orthopedic guys around, so he had to do things like that. And we do mission trips and things like that. And the last thing is just common sense. I mean, I think as surgeons, we're concerned about paying folks doing surgery, learning in cadaver labs and doing these types of things. But in reality, they could probably learn how to do it. We just want to make sure they can handle the complications. There's a lot of different levels of training that we just don't understand, like podiatrists. My brother's a podiatrist. Some of the podiatrists are horrible. They have 6-month residencies, 1-year fellowships, things like that. He did a 4-year residency. He does complex foot and ankle stuff. And we have podiatrists on staff with us, and they do a great job, and so you can work with them. And the last thing is that, as what I was talking about earlier, is I don't do kyphoplasty anymore because if you start doing kyphoplasty, vertebroplasty, for every case you get about 10 of these in your clinic. And you got to deal with osteoporosis and the stuff, the end of 20. Yeah. So it's like, I'd rather have the radiologist do that because I'm going to do it in the OR with the patient under general anesthesia, so I don't have to deal with this stuff. They can bring him into the radiology suite and do it as an outpatient and do it percutaneously. So in summary, I don't know who should be doing spine surgery. I have some idea of who should be doing it. I do think you should be able to deal with some of the complications or at least have the support to deal with it.